conjunctiva, cornea, and lens and sclera. So all the important high yielding topics, I made sure we have questions from all of them, including a few images. So we will start with the first question. So the first question is about Bitot spots. Bitot spots are seen in deficiency of. That's a very, very straightforward question. It's seen in deficiency of vitamin A. This we've read even when we were in school. So this is not a difficult question. But again, I thought I would like to show you some images of Bitot spots. So one image of Bitot spot is this. Okay, so where you have this kind of whitish image, which is more like a white toothpaste. Okay, so that is a Bitot spot. That is one of the recent morphologies of Bitot spot. Okay, because earlier days we used to get something like this or like silvery scaly ones. So this is frothy appearance. Can you see the gassy appearance? So this was earlier phenotypes. Now recent phenotypes we've gotten this kind of white toothpaste model. Bitot spots are seen in vitamin A deficiency, and your WHO staging, it comes under stage X1B. Okay, X1B. X1A is just a symptom, that is night blindness. X1B is Bitot spots. All right. So this foamy appearance is due to the foam or the gas which is produced by Cornebacterium xerosis, and Cornebacterium xerosis is a commensal of the conjunctiva, a normal commensal of the conjunctiva. Please note it down. So normal commensal is Cornebacterium xerosis. So it is because the gas that it produces, the Bitot spot is foamy. Okay, so these are two important images as well. And I don't know, of late Bitot spots has got the fancy of examiners, so you need to know about it. All right. Now let's move on to the second question. What is the correct order of staining for dry eye? Yeah. So this is actually again a previous year question. So I've given you four options for dyes. Basically, I've given you rose bengal, fluorescein, lissamine green, and phenol red. Now don't worry, phenol red is not something that we use in clinical practice at all, so don't worry about it. Maybe in theoretical questions in old tests, phenol red test and all, but no. So for dry eye, what do we use? So remember this very, very easy mnemonic. Okay, so fluorescein comes first. F. Fluorescein is first. Fluorescein, F, first F, right? So remember, fluorescein is the first dye that you have to put on the patient's eye. Now from that word fluorescein, let's take the mnemonic forward. So F, then L, the spelling of fluorescein, L, and then comes UOR. Okay, R. So FLR. So take the alphabets from the fluorescein dye itself and you get the order. Okay, so first dye would be fluorescein, then would be lissamine green, and last would be rose bengal dye. Is that clear? It's a very, very easy trick to follow. So the easiest trick is, there are two tricks for this question. So fluorescein first, F and F. Okay, so now next trick is take the fluorescein word and then dissect it out. You don't have to dissect it out as such. So once you know the spelling, and spelling is also very easy, we're not even going into the U and O part. F L U O R. Okay, so F fluorescein, then is L lissamine green, and UO, forget it, we don't have any dyes. R, rose bengal. So rose bengal is the last dye. Okay, so this is the easiest way to remember this. Now this is not a falto question. Actually, it is based on a paper that had been published I guess 2 years ago by Ames, and that is why it was asked in ICT. Okay, so please remember this. It's important because people work hard to publish, and it's nice when they ask such questions and they expect us to know something about it. All right, moving on to question number 3. A patient has central guttata on the cornea. Which of the following dystrophies exhibit this clinical finding? Now again, this is from NEET PG 2025. So central guttata. So first of all, there are two important things here. Okay, before I go to the answer itself. See, guttata. What is guttata? Guttata is plural. Gutta is singular. So these are excrescences of the Descemet's membrane. What do I mean by excrescences? projections. So the Descemet's membrane normally is neatly arranged, no? So now there is accumulation at certain points, so that is projection. Yes, excrescences of Descemet's membrane is guttata, all right, are guttata. Now we do get physiologically peripheral excrescences. Now the peripheral excrescences are seen in old age, which are called Hassel-Henle warts. Okay, Hassal Henle, Hassel-Henle warts. These are peripheral excrescences of the Descemet's membrane which are seen in old age. Now that is okay, that's a physiological finding, just like hair turning grey. But central guttata is abnormal. Now central guttata are seen in endothelial dystrophy. And what is the most common endothelial dystrophy? Fuchs dystrophy. Okay, so Fuchs dystrophy is the answer. So in Fuchs dystrophy you get central guttata. Is that clear to everyone? Now a few more things. Now the central guttata on slit lamp, yes, it will appear as projections. On specular microscopy, they'll appear as dark spots. Okay, they'll appear as dark spots because nowadays the standard of questions is increasing because of the increasing level of competition, maybe, or maybe you all are that smart and intelligent. So probably next time they might say on specular microscopy there are dark spots seen between the hexagonal cells or between the hexagonal cells. So these dark spots represent guttata, and when they are centrally located, it is in Fuchs endothelial dystrophy. That is why you get this appearance called as beaten metal appearance. So FMG students, one-liners for you. Beaten metal appearance of the endothelium is seen in Fuchs dystrophy. Okay, now a few more points on this Fuchs dystrophy, because maybe they are going to give you a clinical scenario based on this Fuchs endothelial dystrophy. So when my endothelium is not functioning, what is going to happen? The endothelial pump obviously is not going to function. So there will be accumulation of water in the stroma. So there's going to be stromal edema. Yeah. Now this stromal edema in the initial stages probably it will clear off, but later it is not going to clear off, and it is going to move into the epithelium, forward into the epithelium, causing bulle. So you do get bullous keratopathy in Fuchs. So when you get bullous keratopathy in Fuchs, then the patient starts getting pain, because bullous keratopathy is a painful condition. Okay, so especially when the bulle rupture and the corneal nerve endings are exposed, and every time you blink, it touches, the lid touches on the exposed corneal nerve endings. Are you following me? So it can become painful. So when Fuchs endothelial dystrophy becomes painful, it is because of the bullous keratopathy. Is that clear? Okay. Now you can later, what can happen is there can be stromal scarring. Stromal scarring can happen because when you have stromal edema, it ruptures your stromal collagen, and then new collagen will be deposited. And I've always told you, new collagen is not as regular as the original collagen. It's always irregular. The moment the collagen is irregular, it loses its transparency. So you got this scarring or opacity. Is that clear to you? Now the management of Fuchs, as long as I do not have stromal scarring, yes, we can do just an endothelial keratoplasty. Just remove the diseased endothelium and replace with a donor endothelium. Yeah. But if this stromal scarring has occurred, then there's no point. Even if I do an endothelial keratoplasty, the patient is not going to get vision. So in that case, I will need to do a penetrating keratoplasty. Do you get my point? Yes. Beta, I'll come to your question. I'll come to your doubt a little later. Okay, let me just finish this. So treatment or management of Fuchs endothelial dystrophy for bulle, yeah, hypertonic or saline and all that for the bulle part and the soft contact lenses. But the treatment of choice is you have to replace the diseased endothelium. So you do an endothelial keratoplasty or a posterior lamellar keratoplasty. But if my anterior lamellae is involved, in the sense if there is stromal scarring, if there is stromal scarring, then just doing an endothelial keratoplasty is not going to help. So in that case, we'll have to do a penetrating keratoplasty. What is penetrating keratoplasty? Full thickness keratoplasty. Is that clear? Okay. So third question is over. So the patient who has central guttata on the cornea, what is the most likely diagnosis? It is Fuchs endothelial dystrophy. Now, which of the following is utilized in C3R treatment? Now, what is C3R? C3R is corneal collagen cross-linking. 3 C's using riboflavin. So, C3R. And C3R is a treatment of choice for keratoconus. Okay. Again, FMG students, one-liner, write it down. It was a previous year question for you FMGs. So, what is the treatment of choice for keratoconus? It is C3R. Is that clear? All right. Now, coming to what is used in C3R. Remember RUVA. Okay, remember RUVA. Now, if you remember your psoriasis treatment, there is PUVA. You use PUVA, right? Now, for C3R, it is RUVA. Now, what is this RUVA? Riboflavin and UVA light. Okay, riboflavin and UVA light. This is again a previous year question. Now, there are some procedures where we also use oxygen. Yes, we augment the oxygen. There are certain procedures where the atmospheric oxygen is just like that utilized, or sometimes we use a nasal cannula. We just place it around the eye to, give oxygen. So maybe even oxygen. Yeah. So these are things that are used in C3R, which is treatment of choice for keratoconus. Hi beta. Hi Montu. All right. Moving on to the 5th question. A 55-year-old male patient is able to read the newsprint without his glasses. Wow. So unaided near vision is N6, which is perfect vision for near in both the eyes. Now, best corrected distant vision is 6/18, which he is not able to see distant vision properly. Okay. What is the most likely underlying cause? So here is a 55-year-old patient who is a presbyopic patient. Yes. So 55 and you expect presbyopia, right? A problem with near vision because it's an age-related condition. It's just like, let's say somebody is 60 and hair is black. I don't think that's his normal color. Something is fishy. So like that, if somebody says that 55 and I can see near print absolutely well, either they are a very, very high myope, probably yes, or otherwise something is happening. And here's what is happening. His near vision, he has been reading using glasses. Now he is no longer needing those glasses, but his distant vision is poor. So that means he has a cataract which is making his distant blurred, but his near vision is good because nuclear sclerosis has developed in this patient. Yes. So the answer is nuclear sclerosis, which again is a previous year question. So nuclear sclerosis, what happens? The nucleus becomes harder. So the refractive index increases. So you got this phenomenon of index myopia. So when you have myopia, the image is in front of the retina, correct? So his distant image is actually in front of the retina, which is making his distant image blurred. Because let's say this is my retina and the image is in front, the distant image is front. So what is formed on the retina is a blurred image. So that is why his distant vision, best corrected visual acuity is just 6/18. Whereas his near, which is originally behind the retina because he is presbyope, and now that has moved forward and it is on the retina. So it's perfectly clear for him. He doesn't even need his glasses. Okay. So this is called second sight of the aged for near vision. Okay. So this is the concept of second sight. But what is the underlying diagnosis or the underlying cause? It is nuclear sclerosis. He will need a cataract surgery, right? So that is the answer. Now, some of you who mark presbyopia, no, he is presbyopic, but now that presbyopia for some time because of his nuclear sclerosis, it is corrected. But look at that, his distant vision also you have to take into consideration. You have to see the patient as a whole. Okay, definitely he is presbyopic. Yes. Why is the video stuck, beta? Is it like that for everyone? Because for me it's streaming. Is there a problem? Just let me know the others. Okay, now moving on to the next question. Which of the following IOLs is used to correct astigmatism? Paul, no? Alright, thank you Swarna. No. Now it's okay, Paul? Alright, good. Which of the following IOLs is used to correct astigmatism? So for astigmatism, I always told you it is the one which has the axis which is marked on the optic, which is toric IOL. See, whether it is contact lens or IOL, if it is correcting astigmatism, it is toric. Okay, it's a toric surface. See, basically toric surface is a spherocylindrical surface. Yeah. So toric IOL is a straightforward answer. Let me anyway read out the other answers. Options: monofocal PC IOL, no. Monofocal PC IOL is basically to correct your distant vision. Yeah, distant vision. Maybe you can use monofocal for correcting near vision by using this concept of monovision. What is monovision? You identify the dominant eye of the patient, in that you slightly overcorrect, okay, make the patient myopic in that eye, in the dominant eye. And in the non-dominant eye, you either make it emmetropic, I mean calculate the IOL in such a way, make it emmetropic or slightly hyperopic, so the patient gets this his near vision. He can manage near. So that is the concept of monovision, for which we use monofocal. We don't go for multifocal, even with a monofocal IOL. So in the dominant eye, I don't know why I'm showing this, because this is my dominant eye. So dominant eye, you put the correct it a little, so that the patient is left a little myopic, and the other eye you leave it emmetropic or slightly hypermetropic, so the patient will not need near glasses after cataract surgery. But that is only if they ask about monovision, okay? Or you're answering very well in your Viva, because I know third years are watching this. Now ACIOL, there's no concept of doing this monofocal and all that. It's just like you've done there's some problem intraoperatively, we had some problem and we had to put an IOL, we put an ACIOL. So in that there's no concept at all of this correcting astigmatism or presbyopia. Toric IOL, which is the answer. Accommodating IOL is for correcting so that the patient does not need near glasses. So in accommodating IOL, till now we do not have the concept of toricity in that. Maybe in the next few years we might even come up with toric IOLs. We don't know. As of now, there's no toricity in accommodating IOL. Alright, we'll have to wait and watch. Now, a patient presents with redness, pain and reduced vision in his right eye. Beta, whatever is your questions, I'll come to it towards the end, please. Just leave your comments, I'll come to your questions a little later. A patient presents with redness, pain and reduced vision in his right eye. His condition was diagnosed as posterior scleritis. I'm already happy. Okay, they already given us a diagnosis, but still I'm worried. Why redness in posterior scleritis? Can it be? Okay. Now, what is the cause of his decreased vision? That made my life easy. Now, don't go back to this redness and harp on redness. See, redness usually is not there in posterior scleritis. But again, when it spills over, okay, when there is an anterior involvement, sometimes can have, yeah. Just like, we do have other interests, no? I am an ophthalmologist, but still I do have other interests. You can't prevent me from having other interests. So like that, a posterior scleritis can extend a little anteriorly. So in that case, I will have some redness. So typically it is restricted to behind the equator of the eyeball, and anterior scleritis is anterior to the equator of the eyeball. But yes, there can be extensions. So they are diagnosed as posterior scleritis, and what is the cause for decreased vision? Okay, let's read the options. Subtenon fluid. Guys, subtenon fluid is there in posterior scleritis. But that is the reason for the T sign that you get on B scan, on MRI. Yes. But that is not the reason for decreased vision. Do you understand? Subtenon's fluid is responsible for the T sign, the horizontal T that you see on B scan and on MRI. Nothing to do with decreased vision. Subretinal fluid, yes. I don't know why the least number of people have marked subretinal fluid. I've taught you, I made you write in the workbook also. Subretinal fluid, that is serous retinal detachment, or maybe you read serous retinal detachment and forgot to associate it with subretinal fluid. Whenever you have serous retinal detachment, the hallmark of serous retinal detachment is the shifting fluid of the subretinal fluid. Yeah. So subretinal fluid, if you have, that is serous or exudative retinal detachment, and that is the reason for decreased vision in posterior scleritis. Okay, write it down. Subtenon fluid is for the T sign. Decreased vision in posterior scleritis is because of the subretinal fluid or the serous retinal detachment. Hi, Rijul. All right. Question number 8. What is the most likely diagnosis? So the image is this one. Yeah. So what do you see here? You see pigmentation in the sclera. You see periocular pigmentation. Yes. So this is a very straightforward nevus of Ophthal. Okay. It's not blue sclera, because blue sclera, yes, there is blue sclera, but you have to see the patient as a whole. Okay. So I've asked what is the most likely diagnosis. So the diagnosis is nevus of Ophthal. Lish nodule is seen on the iris Iris is not even in focus in this question. Sturge-Weber syndrome, you know guys, Sturge-Weber syndrome is one half, and you have capillary hemangioma, sorry, not capillary hemangioma, you got this hemangioma, capillary hemangioma, involving this one half of the face. It's not this. Muskan, I am teaching you. Can you please be a little patient? Okay. Now, nevus of Ota, and there were questions which you had asked me. What is nevus of Ota and nevus of Ito, ma'am? See, nevus of Ota is when you have this. Nevus of Ota and Ito. Remember, Ota, O, ocular involvement. It is ocular dermal melanosis. Ota, it starts with O, so ocular involvement. So primarily V1 and V2 distribution mein, when you have this melanosis, that is nevus of Ota. Is that clear? Yes, put this in your mind. Ota. See, I2 also has an O. Now that O comes later. Ota is O is the first. So ocular dermal melanosis primarily in V1, V2 distribution. Take this V1, V2 distribution. Now, nevus of Ito, again same, there is pigmentation, but the distribution is different. Where? Along the lateral cutaneous nerve and your posterior scapular nerve. That is lateral cutaneous nerve, I guess, is one of the branches from the brachial plexus. So, lateral cutaneous nerve distribution and posterior subcapsular nerve, along that when you have this pigmentation, that is nevus of Ito. Is that clear? Okay. Now, coming back to nevus of Ota, why is it important? Because there was a previous year question and you need to know this. There are two complications. Okay. The most common complication, which is glaucoma. Yeah. Secondary open angle glaucoma, where these melanocytes can actually clog the trabecular meshwork. So, secondary open angle glaucoma is the most common complication, and a little scary complication is uveal melanoma. Yes, uveal melanoma is a scary complication. So these two complications. So when a patient has nevus of Ota, whatever age you see that patient, every year the patient has to come back for following up for these two complications. To follow up for these two complications, what will you do? One, for glaucoma, you'll do IOP, measure IOP every time, annually, every year. And to look for uveal melanoma, you'll have to do indirect ophthalmoscopy. To look up to the ora serrata, you'll have to do a fundus examination, dilated fundus examination using indirect ophthalmoscopy. Is that clear? So fundus exam and IOP, these are must for these patients. Every year it has to be done. Is that clear? Now, will everyone develop uveal melanoma? No. People who have these kind of mutations, gene mutations, see, generally people who develops uveal melanoma, you do have some mutations for malignant melanoma of choroid. Just like for retinoblastoma, you have RB gene which is located on 13q14, that is retinoblastoma. So uveal melanoma, for that also you have some genetics. So one is you can have BRAF gene mutation, NRAS gene mutation, GNAQ, GNAQ, write it down. BRAF, NRAS and GNAQ, GNAQ. Okay, so these three genes and monosomy of chromosome 3. Okay, so chromosome 3 ना बेचारा widower हो गया. Okay, उसका pair नहीं है. Monosomy of chromosome 3. Or there's a gain of function of 8q. 3 has lost the other half, monosomy. 8, 3 को ज़्यादा हो गया. So gain of function of chromosome 8 long arm, 8q. So these kind of people are at a higher risk of getting uveal melanoma, because in the West, you know, there's this, once you see nevus of Ota, definitely send the patient for genetic counseling, and the genetic counselor will make sure that the patient gets genetic testing done for all these, so that we know if the patient is at low risk or high risk. So that is why we got to know all this. But in India, it's not very common, I mean, because it's not very affordable for the patients, but you need to know. So what are the genes I told you? BRAF, NRAS, GNAQ, GNAQ, monosomy of chromosome 3 and gain of function of 8q. So all these people generally have a higher risk of, these are the genes or the genetics that is involved in malignant melanoma of choroid. and the same genes, genetics, if the nevus of OTA patient has, again obviously have a higher risk of uveal melanoma. Okay, so all these about nevus of OTA. And question number 9, which of the following layers is responsible for the shape of the cornea? This we've discussed in the classes. It is Bowman's layer. That is why we shape the Bowman's layer, and in PRK especially, photorefractive keratectomy. Yes, so not stroma. Basically it is Bowman's layer. Yeah, Bowman's layer is responsible for the shape of the cornea. So those of you who marked stroma, learn it. It is Bowman's layer essentially. Okay, now we're talking about the normal cornea. We're not talking about the refractive procedures. Okay. Now the last question had an image. So this is the image which has these fine lines. Can you see the fine lines? So this is cornea verticillata. And what was the question about it? Achha, identify the clinical finding. Hyperpion, no. Glad nobody marked it. Casaflasia ring. Guys, casaflasia ring will have a golden yellow ring near the limbus. There's nothing here like that. Cornea verticillata. I don't know why some people thought Voigt's limbal girdle. No, it's not Voigt's limbal girdle either. So can you see, all of you, can you see these fine lines, gray lines in the inferior part of the cornea? So this is cornea verticillata, also called as your vortex keratopathy. Alright. And what is the most common cause of vortex keratopathy? It is amiodarone. And guys, please write it down. Just because my patient got this cornea verticillata in a patient on amiodarone, do not stop amiodarone, because amiodarone is given for atrial fibrillation, and if you stop this drug, the patient will die. Yeah, it will turn fatal for the patient, and this thing is not even going to affect vision. Okay, it will not affect the vision of the patient on amiodarone and getting this cornea verticillata. So please do not stop the drug. It is seen even in therapeutic levels of the drug. Now, point number 2. Patient on amiodarone develops decreased vision. Must be because the amiodarone affects the optic nerve. You remember toxic optic neuropathy claimed A? One of the A's were amiodarone. See, amiodarone can affect the optic nerve. So if patient on amiodarone develops decreased vision, do a fundus examination. If drop in vision, stop amiodarone. If there's no drop in vision, don't stop amiodarone. If there's drop in vision, it must be because of the optic nerve getting affected. Do fundus exam and then probably switch the patient to an alternative drug. Okay, now let me look at your comments. HSV endothelitis, ma'am. See, HSV endothelitis is basically the viral disciform keratitis. See, disciform keratitis primarily is an endothelitis. That means, although we talk about it under stromal involvement, the primary disease is an endothelial inflammation. Okay, so the endothelial inflammation manifests as keratic precipitate. So you will have inflammatory cells sitting on the endothelium. Now, when it is an endothelitis, your endothelium is not going to function. Even if it is an inflammation, it's not going to function. So what's going to happen in that? So basically, it's a localized endothelitis. Okay, it's not diffuse to start with. So you will have loss of function of the endothelial pumps in that area. So you'll get a stromal edema exactly overlying the keratic precipitates, like a disc of stromal edema. So that is why we call it as disciform keratitis, and this is a type 4 hypersensitivity, meaning it's a delayed type hypersensitivity. So that is why I always tell you, remember D for D. Disciform keratitis, delayed type hypersensitivity. Okay, type 4 hypersensitivity, and this endothelitis will spread into the trabecular meshwork, causing trabeculitis. So when your trabecular meshwork is inflamed, definitely the aqueous outflow is going to be impaired. So aqueous is not going out, IOP will be increased. So that is why in this HSV keratitis or endothelitis, there is also increased IOP that you have to deal with. And because it is a delayed type hypersensitivity, you have to give topical steroids. You give topical steroids because it's basically a hypersensitivity. You may not always need a topical antiviral, but again, depends. If there is overlying, if there is epithelial involvement, we may want to give topical antivirals, but definitely topical steroids and drugs to decrease intraocular pressure. Okay. So that was Motajul, right? So I guess your doubt is cleared. Okay. Muskan. See, today's topic is conjunctiva, cornea, and lens and sclera beta. Your question is out of syllabus for today. So you join us in the subsequent sessions whenever your doubt, it falls under the purview of my topics. That day I will discuss it. All right. So just be patient. I think in a day or two it's coming. Join our Telegram quiz. So you'll know on that day which particular day. See, Parks 3-step test I have already taught you in the previous video also. Just go back to which day we did this, yeah? I think recently we did it, no? And I actually posted the link to the Parks 3-step test. What you can do is, Muskan, you can just go to my channel, open my channel and just type Parks 3-step test without pen and paper. Okay, I've explained it in detail. You can watch that. See, this is not a squint topic today, Muskan. So whenever there is a squint topic, that day I'll definitely I'll take up your questions. Okay. So you wanted about Hess chart and muscle. Okay, I'll definitely explain it to you. So you do join us when we have the squint. I think it's on FAQs 4 session. I guess it's on the last day, if I'm not wrong. So please join us on our Telegram quiz, and you'll know. So because I want to keep the discussion pertaining to this, because Motajul asked a cornea based question, so I took up that doubt. If you have any doubt, any questions on conjunctiva, cornea, lens or sclera, I'll be more than happy to explain today. Guys, any other questions? Have we completed first of all the 10 questions from our Telegram quiz? Yeah, we have. So nevus of ota and ito clear. Ota is ocular dermal melanosis. So next time they give the same picture and they ask, and you're looking for nevus of ota, and ota is not there. Ocular dermal melanosis. Okay, that's the other name. So V1, V2 distribution is nevus of ota. Ito is lateral cutaneous nerve and posterior scapular nerve distribution. Okay, same over pigmentation. It's the same thing. Yeah, please do, Muskan. You'll benefit from that. You'll not regret it. So go through our schedule, and whatever doubts you have on your squint, you can definitely, I'll explain to you the day we do that live discussion. Guys, any other questions? Okay, you also wanted prism adaptation test. I'll teach you on that day. Okay. All right. Guys, and if you have any questions, you want me to explain anything, you can always put it down in the comment section, so that, even if it is not pertaining to this topic, and let's say it's for the upcoming test, upcoming quiz, please write it down in the comments, so that I'll make sure that that particular doubt or that particular topic will be covered in the subsequent sessions, appropriate sessions. Yeah. Maybe it will take a day or two, but not too longer. Any other questions, bache? So shall we wind up for the day? All right. So see you tomorrow at 8 p.m. So the quiz is at 6 p.m. on Telegram group, and the discussion will be at 8 here. All right. Bye.